just want to make a correction. It's Sajir. I'm presenting for Anant Joshi.
No problem.
Couldn't
Please,
make it today.
please go ahead.
But I work with him at the clinic. With the clinic, it's called SportsMed in Parel. So primarily we deal with ACL surgery. So in this presentation, we have included management of an ACL right after injury, right up to surgery, post-surgery, and back to field. So I have put how we remotely manage these patients because, as you know, a majority of Anant Joshi's patients are remotely managed and they come into Mumbai for surgery and they fly back to their states. So as we all know, the ACL injury management is a long process. It goes through right from injury, surgery, and back to sports, involves a lot of rehabilitation, minor tips, which the patient constantly needs to be doing. As an orthopedic surgeon, most often we get these WhatsApp images of reports where, like in this patient who had presented to us from Surat, he WhatsApped me. The report stated a complete tear of the medial meniscus and a mucoid ACL of the mucoid ACL. But we asked for the images of this MRI, and when we see the images of the MRI, we try to observe what actual injuries these patients have. And clearly there is a detachment of the ACL from the femoral side, which is complemented by the impact in the bone. So further to understand their injury, we also ask their clinical images like walking, standing, and a picture of both knees together, depending upon the intensity of the injury. If the injury is not so severe, so like this female patient had difficulty in straightening the knee fully, and she had not a significant swelling, very minimal impact, and we share a PDF with them. Essentially, the PDF contains details on how they can manage their injury in the acute, and we advise them that the ideal time for surgery is when the knee is silent. And these are the prerequisites that we include for our surgery, and these exercises we advise them to do, which are basically essentially static quad, static hamstring exercises, which they can follow themselves. And also a video is shared with them, which is also available on our YouTube channel, which the patients can understand and analyze their injury further. So most often we like to get the DICOM images from them, and these DICOM images can presently be viewed on our cell phone devices as well, where we can really study the intensity of the injury, the kind of the ACL rupture, the amount of impact in the bone, based on which we can tweak their initial post-injury management, because sometimes we have very subtle injuries like this player who was doing Malcolm, fell from a very small height, and you can expect a very minimal impact in the bone and just a pull off of the ACL. In these cases, we don't need to immobilize the patient for long. We immediately put them on static cords, maybe not weight bear for a couple of days and get back to rehab. But if in case the injury is much more severe, the same spot but fall from much more significant a height, we should suspect more collateral ligament involvement or significant impacts in the bone, which if supplemented with an image of the knee which shows significant swelling, we almost always allow the patient non-weight bearing for a couple of weeks before they start weight bearing and doing the regular rehabilitation protocol, as in a patient who had a very subtle injury. Also, in such significant injuries, we look very carefully for the collateral, because if there is a complete detachment of the collaterals and if there is a curled up ligaments, we like to call them early so that we can fix things early. We most often don't get such videos, but when we do get, we like to observe the mode of injury that they had. Like this athlete, cricketer, had a fall directly on the knee, and when you have a direct hit on the knee, the most often telltale clinical sign in the MRI correlating with a PCL injury, we like to immobilize these patients initially with a stiff knee brace, which is a push knee splint essentially, which will push the tibia forward. So essentially our management of all these patients, like this Odisha patient had connected with us regarding an ACL injury, we give them some questions, and these questions are basically to understand the kind of injury, the mode of injury, the impact on the knee, the involvement of any cruciates, collateral. We study their DICOM images. Also, we ask them to share their videos of their progress so that we can understand how they're progressing. Like this patient at maybe 4 or 5 days post-injury was using a walker and non-weight bearing, and we ask them to follow up with repeat videos of their progress every 2 weeks just to see how they are progressing. And if we see that they are walking better, we also additionally try to convince them that the recovery of the range of motion and the gait is essential for getting the surgery. And once we are sure that the range has recovered fully and the knee has recovered well, we call them in for surgery. Once the surgery is done, these post-op instruction booklets has been given by Anant Joshi since ages, and these instruction booklets involve details of the injury, what kind of surgery was done, what care they need to do post-operatively, what are the exercises they need to do post-operatively, right up to 9 months post-surgery, what all they are supposed to do by themselves. And all these are also applied in videos on our YouTube channel where they are sent the videos in the initial 4 weeks, what kind of exercises, rehab they need to do, 4 to 6 weeks or 4 to 8 week, what kind of rehabilitation they need to be doing. Some of the post-op issues, like at 3 weeks, this patient not from Mumbai complained that he has some inner side knee pain, which was severe after starting some early activity. Someone told him ACL is degenerated, but the only thing that he really had was some swelling in the bone. So he had a medial tibial plateau stress fracture, which was secondary to early running. He had started running too early. That's why he developed this. Solely activity modification in the initial weeks post-surgery was enough for him to get rid of this problem. So this was an athlete, a national athlete, who underwent a sports massage at least 4 weeks. He was just out of the acute state when he underwent the massage, and he complained that he has swelling, some mild fever, and we checked his CRP, it was quite high. We did a medical management in this case, but most often we do urgently call them back for a washout. But with just medical management in him, the swelling did subside, the CRP levels did reduce. So this was how we managed him remotely when we couldn't access him. Some of the tools which we use, the game ready or just icing, works the same. It's just a cool pack, an ice which keeps, or a cool water which flows through the brace, essentially cools the knee and reduces the swelling. The Faradic stimulation for the quadriceps is very commonly used by us, and this is used in scenarios where we don't have a good quad contraction. We use just the stimulator, and one can observe that with just using the stimulator, the kind of muscle contraction one can get is much better. Such post-operative advices in the form of rehabilitation videos are also shared with the patients, and these patients are even given physio video consults to help them in the post-operative recovery. Our most favorite is the hydrotherapy, is the exercises under the pool, which we have a complete video on our SportsMed YouTube channel, which the patients often start at 4 to 6 weeks post-surgery. And this is the most ideal way for them to regain the range of motion. We send them this video and ask them to do these exercises in waist-deep water in a pool access. Some of the smart knee braces which has come up, which is still being designed, is one that designed by Donjoy. But these braces can give the physician real-time feedback on the range recovery, on the bulk recovery, on the usage of the knee recovery. But these things are still being researched. We have no experience with these. The BFR, where essentially a tourniquet is applied on the knee and the exercises are done, improves the anaerobic activity of the muscles. It's very dicey. I don't vouch for this. This was shared by one of our sports physiotherapists. Muscle testing is out because most often it is so obvious on the muscle recovery, so we don't do a lot of muscle testing currently. But if you are confident on the amount of muscle bulk that the player has regained, we almost always put them back on proprioceptive training, on-field training, and back to sports. One last slide, which can be a future recommendation, would be this activity tracking apps, which one of our friends has been designed, can be used to incorporate into our post-op remote management system in the form of a software, so the patient can send their immediate post-injury videos. We can share them how they need to manage them post-injury initially, and we can also share with them the rehabilitation that they need to follow, which can result in a complete return to sports. Thank you.